Good afternoon, dear audience. It's 3 o'clock already, but let's wait a while so some people can join the platform. Thank you very much. Dear audience, it's 3 o'clock already, but let's wait a while so some people can join the platform. Thank you very much. Dear audience, it's 3 o'clock already, but let's wait a while so some people can join the platform. Thank you very much. Thank you very much. Good afternoon, dear participants. Want to thank you for joining us again for the November edition of IAMRAT lecture series. We are grateful for always keeping time with us. Thank you very much. This month's lecture promises to be very interesting and very educative. Please permit me to briefly give us a background of the Institute for Advanced Medical Research and Training. The Institute was established in 1980 and one of the academic division of the College of Medicine of Ibadan, primarily for coordination of multidisciplinary research program in the college. It is a response to address the limited institutional capacity in Nigeria for strengthening training, research, and policy development in the area of health. The institute has a track record of excellent research of financial standard channeled towards relevant and global health problems. The institute has had a complement of trained staff with expertise in many fields of study. I'll just mention a few of them: epidemiology, biostatistics, cancer research, drug research, genetics, malariology, entomology, molecular biology, neuroscience and aging, medicine, and with funding from several local and international agencies, which include WHO, NIH, and so on and so forth. The institute is famous for research in infectious diseases, particularly malaria, for which was designated a center of excellence in Africa, and also non-communicable diseases, which included breast cancer, sickle cell disease, stroke, and dementia. The institute has numerous research and administrative units, which included the following: genetics research unit, drug and cancer research unit, malaria research, molecular entomology, neuroscience and aging unit, epidemiology, car and biostatistics research unit, neurodegenerative unit, palliative care. And domicile in the institute is also the University of Ibadan, University College Hospital Ethics Review Committee, the top research ethics committee that was established in 2002. Leading the institute is a director, and our current director is Professor Ekeoluwapo O. Ajayi, who is very much present on this platform. I'll now hand over to Director Professor Ajayi to give our opening remarks. Thank you very much. Professor Ajayi, you have the floor. Professor Ajayi, you have the floor.
Good afternoon, everyone. You are welcome to this month's lecture, and we are happy to have you all. I would not say much other than to thank our dear Professor Adesola Odole, who gladly accepted to give this lecture to us. And our profile will be read soon, but I can just mention that she's taking us into the world of physiotherapy, which I believe many of us will require at one point or the other as we journey in this world. And with aging, this also comes to be. And for this afternoon, she's going to talk to us about a shift in this healthcare system that would provide us with meaning and impact, and also let us know whether we're dealing with patients or with persons. And that I can very much relate to, because we always mention that we should deal with our patients as persons and not as patients or cases. So she's going to put us through this in the next 1 hour or so. Please just enjoy the lecture. And once more, Professor Odole, you are welcome. And we look forward to this very interesting lecture going by your topic. Thank you, everyone, for coming. So let us have the...
Dr. Bakare, please, can you read the profile of our lecturer for today?
Good afternoon, everyone. My name is Dr. A.S. Bakare from IAMRAT. I'm to present the dissertation or profile of Professor Adesola Christiana Odole. Adesola Christiana Odole is a professor of musculoskeletal physiotherapy and health outcomes assessment, and a consultant in musculoskeletal orthopedic physiotherapy at the University College Hospital, Ibadan. She is presently the head, Department of Physiotherapy, College of Medicine, University of Ibadan. She can be described through the lens of an educator, a researcher, and a clinician. She is the chair, e-learning committee, College of Medicine, University of Ibadan. Her teaching, scholarship, and clinical practice have been geared towards musculoskeletal health, that is particularly in the elderly, health outcomes assessment, chronic non-communicable disease epidemiology, physiotherapy education, and digital health interventions. Working with other researchers, she developed a Nigerian culture and environment-friendly health measuring scale, the Ibadan/hip osteoarthritis outcome measure, ICOHAM. The ICOHAM was the first contribution to standardized outcome measures in English medical literature by Nigerian authors. She is passionately interested in improved access to healthcare for the marginalized, that is, particularly persons with disabilities and elderly and undeserved communities through digital health interventions. She is a strong advocate for inclusion of persons with disabilities in climate change. She is on the advisory board of Sustain Our Abilities, that is non-governmental organization NGO on climate change and persons with disabilities, and Rebuilding Hope on the Wheels Initiative, that's NGO on persons with disabilities in Nigeria. She is a global ambassador on climate action with the Global Environmental and Climate Conservation Initiative. She has avid interest in advancing health, that is, in a person-centered approach, and promoting health outcomes, particularly in musculoskeletal health, through education, advocacy, and research. She is a recipient of various fellowships, scholarships, and awards. She is widely traveled and has made over 100 presentations at national and international conferences, seminars, and symposia. Furthermore, she's a reviewer of many local and international journals, and she has over 145 scientific publications in visible, index, and reputable peer-reviewed journals. She is a member of the Board of Trustees of the Association of Clinical and Academic Physiotherapists of Nigeria, and was the pioneer chair, Scientific Council of the Association of Clinical and Academic Physiotherapists of Nigeria. She's a research affiliate of the Practice Institute of Global Population and Economy, University of Lethbridge, Canada, and an associate member, School of Graduate Studies of the same university. She is a member of the Board of Directors of the International Society for Quality of Life Research, a global community researchers, clinicians, healthcare professionals, industry professionals, consultants, and patient research partners advancing health-related quality of life practice, policy, and research. With this great citation of Professor Adesola Christiana Odole, Prof, you have the floor. Let's now listen to her as she presents her lecture for today. Good afternoon, Prof, and you are welcome.
Thank you. Thank you very much. Can you all hear me? Hello, can you hear me, please?
We can hear you.
Okay, thank you.
Very well.
Can you see my screen?
Yes,
We can.
yes, we can see you. We can
My
see your
screen.
screen.
Okay, can you see my slides?
Yes.
Not yet. Not yet.
Okay. Yes, that's what I'm trying to do. Just a minute, please. It appears my cursor is hanging. Please just permit me to, I'll just leave shortly. Maybe I'll come in again. I don't know why the cursor is not picking. Cursor on my laptop. I don't know why this is happening at this time.
It's easier for you to just reboot and come back on.
Okay,
Otherwise,
I'll do that.
it will take a long time.
Okay, I'll just do that straight away.
So good afternoon, everyone. While we're waiting for Professor Odole, kindly register and also indicate if you will require CME scores. I have posted the link to the registration form. Thank you.
Can you see my screen now?
Yes.
Yes, please.
Okay, thank you. Thank you very much. I want to start this presentation by appreciating the management of the Institute for Advanced Medical Research and Training, IAMRAT, ably led by Professor Ikeoluwa Ajayi, for the honor bestowed on me as the guest lecturer for the IAMRAT lecture series for the month of November. I'll be speaking basically, it is not entirely physiotherapy related, even though when I begin to make examples, please permit me to make examples in the field that I'm really very conversant on, and that is physiotherapy. So this afternoon, I'll be talking on something that I hold very dear to heart, so a concept that I cherish so much, person-centered care. And the title of my presentation this afternoon is Patient or Person, the foundational shifts that redefine healthcare meaning and impact. So I'm trusting God that this afternoon that I'll be able to bring to fore the philosophy behind the philosophy of the person behind the patient is a philosophy that I'm very passionate about. The person behind the patient for impactful and meaningful practice. And specifically, I will be examining the International Classification of Functioning, Disability and Health framework. I'll be discussing the Therapeutic Alliance to keep the patient in the loop. We'll be exploring the power of patient-reported outcome measures in shared decision making. And I'm hoping that we would all be able to identify how to integrate a shift from healthcare provider-centeredness to patient-centeredness if we must make meaningful impacts in the delivery of care to our patients. I want to recognize the presence of very senior colleagues here, healthcare professionals, students, non-clinical professionals, ladies and gentlemen who have taken their time to listen to my presentation this afternoon. So the outline of my presentation will be, I'll be setting a little bit of the scene by providing background information. I'll be talking about the flesh of today's presentation, foundational shifts beyond disease to the individual. And I'll also be talking about mastering the Therapeutic Alliance, measuring what matters to the patient. There's no way we're going to focus on person-centered care without looking at health measurements in relation to the patient's perspectives. We would look at individual and population health statistics from the perspective of what actually is important to the patient. Then I'll briefly talk about disability-adjusted life years, and we would look at how we'll be able to integrate strategies for systems-wide adoption in this person-centered care of management. So in a bid to set the scene, I want to ask a question. When we treat a patient, who are we really treating? Is a question for every one of us on this webinar to ask. Do we just focus narrowly on the disease? It's very important that we focus on the disease, but is that just all we focus on? Just to know the disease and manage the disease? Or do we reduce the encounters that we have with our patients with just getting a diagnosis? We just refer to a patient. And that brings me to something that happened several years ago, about 15 years ago, I think, thereabouts. I was on a social visit on a ward in the hospital. I came to see an elderly woman that had just had a surgery, a relation of a friend of mine. And while conversing with the woman, by the bedside, she told me that she's really very disturbed that after 7 days of her surgery, she's not been able to walk around her bed. And I just felt, I think Mama should have been referred for physiotherapy, even from day one of our surgery. And incidentally, on the ward, I saw the consultant on the ward, and I approached the consultant, I introduced myself, and I just told the consultant my concerns. And the response of the consultant then was actually very, very absurd, because he just told me that the mama is patient. The mama is patient, and that he will decide on whatever he has to do with his patients. So that is a reductionist approach. When we use this kind of approach in managing our patients, in managing patients that come to our clinics, it often leads to a disconnect when treatment is technically successful. In that instance of that elderly woman, she had a surgery. The surgery was very successful, but that reductionist approach fails to address what is even important to the patients. The mama wanted to be able to walk around her bed. Sometimes we do not address the individual's quality of life, daily function, and personal goals. And that is why this concept of the foundational shift, there is a shift to seeing a person, to seeing our patient as a person. When we do that, it acknowledges the complex interplay, the interplay of the person's biology. This individual is a person, has a lot of stories, has his own history, has his own family background, has so many things. So we look at the biology, the psychology, the social context, and environment. So this foundational shift is not just about talking about mere semantics. It is something that is morally, ethically, and clinically imperative that redefines the meaning and impact of healthcare. Whatever kind of delivery of care that we give our patients, if we do not look at that, look at these foundational shifts, we will not be able to get desired and meaningful outcomes. So the foundational shifts beyond disease to the individual, beyond disease to the patient, and now moving to the individual, the person. And that takes me to talk about the patient-first paradigm. In this patient-first paradigm, which is the paradigm that I'm advocating for, and that I'm hoping that at the end of this presentation, there will be a movement. There will be a movement supporting this patient-first paradigm, where we recognize that our patients, when we have a counter with patients, it's not just about data collection. It's not just about collection of symptoms or eliciting signs. It is not just about the case study. These individuals, they have unique histories, like I said earlier. They have their own families, they have their hobbies, they have their fears and goals that we need to look into, because the symptoms that they have brought to us in the clinic, these symptoms, like their physical pain, they are often intertwined with their emotional and social well-being. And basically, for healthcare professionals, and even when we carry out research that borders on patients, we want to be able to have desired outcomes. And that leads me to another terrain that I love so much, health outcomes assessment. But this afternoon, I'm not going to delve into what health outcomes assessment is all about in details, but I'm just going to lean on a classification system that could guide us in our health outcomes assessment when we assess our patients. And that classification system is the ICF. I have a PDF copy of the practical manual for using the International Classification of Functioning, Disability, and Health that I'll be happy to share for any individual that would want to use this framework in health outcomes assessment. The ICF basically has two parts. Just permit me to just run through this, because this will guide us in identifying the variables of interest to the patients that we now need to work on to be able to have desired outcomes. So it has two parts. We have functioning and disability, and we have the contextual factors, which borders on environmental factors and personal factors. The functioning and disability, when we talk about, I'll define some of these terms as we go on in this presentation. And I want to say that while focusing on the ICF, I am not saying that the traditional model is not beneficial, because the WHO also has another classification, the ICD, the International Classification of diseases, which was revised, and that we had the ICD-10, and we now have the ICD-11. The ICD focuses on classifying diseases and conditions and basically talking about diagnosis. But we are saying that we need to complement this traditional model of identifying diagnosis with the ICF framework. The ICF framework, both classification systems were developed by the World Health Organization. The ICF framework provides a comprehensive model in such a way that we classify functioning and disability, not just about classifying the diseases and the conditions. It provides a standard language and a conceptual basis for the definition and measurement of health and disability. Everyone can measure health. Even the patient can assess the effectiveness of the intervention we give him or her. So everyone can measure health and disability. In the ICM framework, it is holistic. It helps us to have an holistic approach in care delivery, where all the variables of interest to the patient, physical, medical, psychological, and social variables are talked about. So going to the definitions, functioning is just an umbrella term for body systems. It's just an umbrella term for body functions, body structures, activities, and participation. And then when we talk about functioning, it's just about the positive aspects. You know, the ICF talks about the consequences of the diseases. It talks about the impact of the disease on the individual, at the organ level, maybe at the cellular, tissue, organ level, the body systems level, and at that, and at the person level, and at the social level, the societal level. So when there are positive aspects of the interaction between that individual that has a health condition and the individual's contextual factors, that is environmental and personal factors, we talk about functioning. Whilst when we talk about disability, disability connotes or denotes the negative aspects of the interactions between an individual with a health condition, that individual that has a health condition that has been diagnosed. You know, that individual now interacting with the environment and with the personal factors. So when we have negative effects of the consequences of the disease, we can talk about disability. So in essence, disability can be a matter of, when we talk about impairments, that is when there is a limitation to what that person can do at the body structure and functions. When we talk about limitations for activities, we talk about activity limitations, participation restriction. I will still mention this a bit in the course of this lecture. So body functions. Now just for us to have to, just refreshing our memory or just to help us, at the body functions, we're talking about the physiological functions of the body systems, which also includes the psychological functions. And at the structures, we're talking about the anatomical parts of the body, the organs, the limb, and their components. What exactly is wrong with this patient? And this is similar to the traditional model. And so I talked about impairments earlier on. When there's problem, when the individual has problems at the body, in the body functions and structures, we talk about impairments. And activity basically is the ability of an individual to be able to execute a task or an action. It could be activities of daily living, it could be basic activities of daily living or instrumental activities of daily living, whatever task or an action that an individual is interested in. So when there is a difficulty in executing that task, that there's activity limitation. Whereas participation talks about involvement in life situation, where you talk about social engagement, when you talk about working, you know, parenting, so many things that borders on life situation. And when there are problems when an individual has problems in executing or getting involved in life situations, we talk about participation restrictions. So when we have an understanding of all of these components, it could guide us on the variables that we need to focus on. I will briefly talk about a particular case study as I go on in this lecture. So the contextual factors, like I said earlier, environmental factors that could bother on social support, it could bother on policies, physical environment. I'm sure you agree with me that all of this could either facilitate or serve as or hindrances to whatever outcomes that we want to, whatever treatment that we want to give our clients. And then personal factors, age, coping styles, education, past experiences. And this leads me to, I know that most of the times we've often talked about the biopsychosocial model, which is the foundation of person-centered care, really. But I just want to say that the ICF is actually the framework that guides this biopsychosocial model, because the ICF will guide us when we look at environmental factors, when we look at personal factors. This guides us to build everything that matters to the patient, the body functions and structures, activities, participation. And that is why it is important that when we talk about the biopsychosocial model, we should also refer to the ICF. I briefly want to give us a case scenario that would further buttress what I'm trying to talk about. We can just imagine a 45-year-old female who have decided to call Mrs. Moses, not real name, who sustained a T5 burst fracture following a motor vehicle accident some weeks ago. Basically, this woman lives with her husband and child in an informal housing structure. Husband is unemployed. She's the sole breadwinner in the house. She's very eager to return to work, where she works as an admin clerk. She has these fears that she will not be able to negotiate the 2 flights of stairs at work when she's scheduled to return to work. Prior to the accident, she was very active. She did all the cooking and house chores. She enjoys reading and watching television. She does not smoke, but she drinks socially, and she relies on public transport to go to work and the shops. If you look at all of these concepts, it is not just enough for us to just look at the T5 burst fracture, okay, which we manage is possibly surgically by an orthopedic surgeon. So, but if we only focus on just managing the burst fracture, that is, we're just looking at the health condition and disease, we will not capture all that the patient is very, very concerned about. You can imagine this is where she lives, looking at the sandy terrain that she needs to negotiate to her informal dwelling, the exterior of her dwelling, the communal toilets, the communal tap that she used for drawing water, that she uses for cooking and washing. So in this particular case scenario, time will not permit me to delve too much into it. I just want to bring about the ICF framework. And that is the fact that it is not just about the pathophysiological rationale of outcomes assessment. It goes beyond that to the person-centered care of assessment, of outcomes assessment. So now we already know what the health condition is, burst fracture of T5. Going by what my description of body function, the patient has fracture of T5. There will be damage to the muscles, there will be discontinuity in the bone at the fracture stability. For activities limitation, there will be problems with independent bed mobility, maybe transfer out of bed, walking, and then participation restriction, unable to walk, unable to go back to work or even perform house chore, looking at the information that the patients given the patient. Patient is motivated because she wants to go back to work. And this can actually facilitate the rehabilitation process and the treatment that we want to give to the patient. So if we look at this framework, it helps us to identify what is important to the patient. We also look at what is important to us as healthcare professionals, but we focus more on what is actually very meaningful to the patient. And that leads me to interdisciplinary model of care. There is no way a single professional will manage this individual. This individual that has burst fracture will definitely be managed by an orthopedic surgeon. The individual might need to see a social worker. The individual might need to see a clinical psychologist. The individual might need to see a physiotherapist. The individual might need the intervention of a nurse. The individual might need, so many healthcare professionals. So in a person-centered care, when we focus on the patient, we are talking about interdisciplinary model of care. It is not just multimodal. Most of the times what we do, sometimes we give different kinds of therapy. A single person can decide that, okay, let the patient have this. And then sometimes we work in silos. The physician sees the patient, the nurse sees the patient, the clinical worker, the dietitian sees the patient, the physiotherapist sees the patient. You know, we have multidisciplines, but that is not the real interdisciplinary approach for person-centered care. When we look beyond the disease and we begin to see our patient as a whole individual, it is an integrated approach. You know, the multimodal treatment is now provided by a multidisciplinary team. There's collaboration, whether in assessment, whether in treatment. We share this biopsychosocial model. We look at the common goals. We align the goals to what is important to the patient. And most importantly, we have the same message to the patient. Oftentimes, we have always had conflicts in management. Sometimes you see a physician blaming a nurse, you see a physiotherapist blaming a physician, you see a nurse blaming a physiotherapist, you see, you know, and we have conflicts in management. We do not have the same message to the patient. And this gets the patient very worried and very disturbed. We are talking about looking at the patient, you know, focusing on the patient and saying the same message to the patient. So I am advocating that there should be a paradigm shift. There has been a lot of instances where we as healthcare professionals, we dominate the delivery of care. We are saying that the ICF has mandated us to look at health as a spectrum of functioning and disability, the interaction between the individual's health condition and the contextual factors. So treatment success is not just curing the disease, it is maximizing activity and limitation. And that is about a person-centered outcome. That is, we are looking at an outcome that is defined by the individual, that focuses on their return to personally meaningful activities and roles. The clinical markers are very good because we need them. We need to have the biological markers and the clinical markers to be able to make diagnoses. But in looking at the person, looking at the patient as a person, we need to go beyond that. We need to go beyond just having the lab values. We need to talk about when the individuals can be able to do what is meaningful to them. And another thing that I experienced some years ago, I had a patient that had a stroke. And this patient, I got involved because the patient had to do an MRI and I needed to support the patient financially to get the MRI. But what is really very burdensome, and it is about every one of us, all healthcare professionals, it's not just about this case of the MRI. The patient paid for the MRI, but the patient did not have a feedback as to what exactly is the test, the investigation all about. The patient paid for this MRI, the patient should be informed. In a person-centered care, patient needs to know exactly what is being done. We do not just take blood pressure without interpreting the results to the patient. We are talking about patient-centered care. There should be a paradigm. We are all healthcare professionals. We are stakeholders. So we have so many stakeholders in clinical decision making. When we need to make decisions, whether we need to make clinical decisions as to diagnosis, as to treatment, as to referral, as to prognosis, whatever form of decisions that we have to make. As clinicians, we are stakeholders. Whether you are in the health system administration, whether you are into policy making, whether you are a researcher, whether you are a third-party payer of health, you are an insurance person, the patient, who is the person that we are considering, should be seen in the center of our clinical decision making. We have often talked about evidence-based practice. We often advocate for that we should integrate evidence-based practice into what we do at most times. So in evidence-based practice, I'm going to be leaning on what is actually very important, even though in clinical decision-making, whether you are collecting data, you are analyzing your findings, you are setting goals, you are planning your treatment, you are intervening, you are evaluating, the patient must be at every step. The patient seen as a person must be at every step in the clinical decision making. So in evidence-based practice, like I was saying earlier, it's a decision-making approach that we often look at in healthcare. It is the conscientious, explicit, and judicious use of best scientific evidence in making decisions about the care of individual patients. I know that we focus so much on best research evidence, very important. Clinical expertise, very important. Evidence-based practice is not about conducting research, it's about using the research. We often do that. We use the research, even though I may not use the word often. But one major pillar that I'm not sure that we often consider in our evidence-based practice is the patient-client values and preferences. And then when I talk about that, it's not just about giving the patient what they want, or provide information to them. It is about interacting with them with dignity, with compassion, and respect. So if we have to look at patients' and values and preferences in evidence-based practice, that means we have to move. We have to move from the paternalistic approach of healthcare professional dominance. That's approach that views patients as passive recipients of care. We have to move to an approach that allows us to have a therapeutic alliance with our patients, that brings the patients at the center of decision-making, that empowers the patient. And person-centered care and empowerment of our patients is a key aspect of quality of care. We are not just making decisions for the patients. We are getting into the patient's world. We are not just making decisions for them only, but we are making decisions with them. We are encouraging them to perform activity. We are encouraging them to have activities for them, with them, rather than just delivering care to our clients. And that is a major tool for a patient-centric care, therapeutic alliance. Communication. Communication is the most important component in person-centered care. I know that sometimes we have very busy clinics that we often do not have time to communicate. But I have found out from experience that when we take time to communicate, sometimes when I have clients, when I have patients in the clinic, the first day I do not even treat. I communicate. I imbibe this skill of active listening, mastering the therapeutic alliance, the power of listening. Most of the times, a strong therapeutic alliance is something that is collaborative. We are looking at the affective aspect. It's like we want to create a bond between the provider and the individual, and it is the most critical non-pharmacological element in successful care. Like I said earlier on, it's about building trust, empathy, and having mutual agreement on goals. So the healthcare provider moves from being the singular expert. They are now getting the patient as partner in their own care. The patient is an individual, is an active partner rather than a passive recipient of care. So active listening skill, very important. Most of the time, we often hear our patients, but we do not often listen. Hearing is passive. Active listening is a purposeful, conscious process of understanding the other person's perspective. And there are so many techniques. I will just run through some of these techniques now. Non-verbal cues, maintaining eye contact. Just as simple as maintaining eye contact, nodding, having a relaxed posture, letting the patient know that I am here with you. Sometimes we could paraphrase, we could reflect, we could say, oh, Mr. XXX, I presume that this is exactly, are you trying to tell me that, just paraphrasing and repeating what the patient has told you? Open-ended questions. Data collection is very important. When we are carrying out our history taking, whether we are collecting subjective data or we are doing objective data collection, open-ended questions, affirmation, validating the individual's experience and feelings, letting the patient know that, yes, you are in the loop of this delivery of care. Your voice matters, your preferences matter, your concerns matter, and I'm integrating all of this in my decision-making, making the care plan their own and not just for them, like I said earlier on. So there is no way we would listen to the patient very well and identify all the outcomes and identify things that are important to them without looking at what matters to them, talking about outcomes that actually matter to them. So we'll be going into, I'll briefly talk about measuring what matters. Patient-reported outcomes, they are very important. We are so used to having our mechanical instruments, so many mechanical instruments that we use across different disciplines to capture data, to obtain data. But my gospel this afternoon is that aside the mechanical instruments, we should also look at patient-reported outcome measures that capture the patient's perspectives about how illness or care impacts on their health and well-being. There are so many outcome measures. I remember several years ago again, and there was a time we wanted to form a team of researchers that are involved in health outcomes assessment several years ago. I'm sure this would have been more than 13 years ago. And the interest was actually spurred on by Professor Adewonke Akikpelu, who actually spurred me on into health outcomes assessment. She was the one that led the team. Then we had Professor Mayo Wawolabi, because he just developed a tool then, the stroke levity scale. We had just developed the Ibadan hip osteoarthritis outcome measures, and we just felt that we should gather together. Dr. Odunayatu was a member of the team. I can't remember the last person that was a member of the team. So it is about we looking at outcomes that capture the patient's perspective. So many benefits about using prompts. There are standardized, validated questionnaires that directly measure a patient's health status from their perspective without interpretation by a clinician. We have so many of them that measure fatigue, depression, anxiety, ability to perform specific activities. We have the EQUAM, we have the Ibadan low back pain disability questionnaire, the stroke levity scale, the Oswestry disability index, the EQ5G. And information or data collected using these prompts would normally enable a data-driven conversation about the effectiveness or even lack of the effectiveness of an intervention from the patient's point of view, not from the healthcare professional points of views. So prompts help us to identify what is most bothersome. This is just for emphasis. They provide a baseline and they help us to track progress in a way that is meaningful to the patient, facilitating a tangible conversation about the impact of treatment. I will briefly talk about a patient that I also had some years ago. I was managing Mama. Mama was about 78 years old. She had adhesive capsulitis and had pain at her shoulder. She had restrictions in movement and restrictions in function, even though I didn't place any emphasis on the function there. I was just so immersed in ensuring that the weak muscles are strengthened, that the pain is relieved, that the restrictions, that there's an improvement in the restriction of movement at the shoulder. And I had managed Mama for close to 2 months. But then a particular day, she called me and told me exactly what was most important to her. And that day actually changed my perspective about managing clients and patients. She told me that what was most important and bothersome to her was that she has not been able to tie her head gear at Gele. She had not been able to tie her head gear since she had this problem. And I had always wondered, each time Mama came to the clinic then, she always had matching Gele with her attire, And I had always wondered that, how was she able to do this? I didn't even know that she employed somebody to be tying the Gele for her each time she has to come to the clinic. And that was what was important to Mama, and I didn't even look at that. So using if I had known about patient-reported outcome measures then, maybe I would have used it to track the progress in a way that is meaningful to Mama. So I believe that we all agree with me that we need to integrate patient-reported outcome measures in our care, in our delivery of intervention for our clients in Nigeria. So sometimes with Professor Akikpelu and one of our mentees carried out a research on the familiarity with knowledge and utilization of standardized outcome measures among physiotherapists in Nigeria. And I'm just looking forward to a time when it will not just be among physiotherapists. We would have a team of researchers that will be able to do it among so many disciplines, multi-disciplines, to look at our familiarity knowledge so that we can generate evidence. We need to generate evidence about the uptake of prompts in Nigeria. And there are studies suggested then that physiotherapists in Nigeria have poor knowledge, seldom utilized, and are unfamiliar with standardized outcome measures, and that the use of standardized outcome measures should be promoted among them. I'm rephrasing this, that every single healthcare professional, that the use of patients with reported outcome measures should be promoted among us. 10 years after that initial survey, another survey was done, and there was an improvement, so to speak. But even at that, there was still a little bit of varied familiarity with each of the 8 standard outcome measures that physiotherapists utilized in that survey. My interactions with patients and experience with patients taught me on to develop the Ibadan hip osteoarthritis.
There's too much background noise. Too much background noise.
Thank you. To develop the Ibadan hip osteoarthritis outcome measure. And this development to me is because we're talking about a foundational shift from the disease, from the patient to the person. I also managed a patient that had osteoarthritis of the hip and knee, then a polygamist. I had managed that patient and I thought I was doing so well, so wonderfully well. And I could even praise myself if I had to do a self-assessment. But on one of the occasions when I managed this patient drew me into one of the cubicles and told me that he's actually very concerned about his sexual life. He's a polygamist, has 3 wives, and that since he's been coming to physiotherapy for the problem, even though the pain is relieved to an extent, but he still cannot perform his duties, sexual activities with his 3 wives. That is what was actually very important to him. And that was what even spurred us on to look at how can we capture this patient's perspective in measuring the effectiveness of intervention. So in a review that we did on the existing outcome measures, we found out that there were so many outcome measures, existing outcome measures, but they do not capture what is important to an average Nigerian. An average Nigerian patient with knee, hip osteoarthritis would want to kneel down to pray, would want to kneel down as a show of courtesy to greet the elderly ones, prostrate, want to use sometimes the use of Asiatic toilet, sometimes they want to sit on a small stool to make meals. So those were the things that were important to our patient, in our own context, in terms of looking at what is applicable to patients in our own context. So we developed we developed the Ibadan hip osteoarthritis outcome measure as a Nigerian environment and culture-friendly instrument for the assessment of the effectiveness of therapeutic interventions in individuals with osteoarthritis of the knee and hip. And the most important thing was finding justification, which based on my interactions with patients, I knew that we needed to do something that would be tailored to what an average Nigerian patient needs. We defined the purpose, we devised the items, we got information even from patients themselves to be able to devise the items, and that is about co-creation. I remember the last month, the speaker also laid emphasis on co-creation, getting our patients as partners. We validated the instruments, we did scaling responses, we pre-tested it, we investigated the psychometrics, we named it Ibadan, so that it would be named with the University of Ibadan, and then we published it. So it's a lot of process. But even at that, we can, there are so many existing measures that we can adapt for use when we talk about the person-centered care. So having explained the background information about the ICF, capturing data, obtaining data from our clients, whatever data that we obtain and we collect from our clients, our patients, we use the data to generate individual health statistics. And when we have pockets of all of these individuals for a different population, different groups of people, we translate it, we transform it to population health statistics. So our individual health statistics, whether we are using mechanical instruments for blood pressure, blood sugar level, cholesterol, blood, triglycerides, or whether we are looking at what matters to the patient, the behavioral and lifestyle factors, activities of daily living, we need to capture all of this. So if we do not capture all of these at the point of history taking, using the ICF framework, we will not be able to have an appropriate picture in terms of population health statistics. Population health statistics, we can use that to assess the health of a community or group, getting the mortality rates, the life expectancy, infant mortality, so many things that we can generate. But I'm saying that for us to be able to generate population health statistics that will be very true and appropriate and accurate, we need to look at it from the concept of the ICF, from the concept of the person-centered care, person-centric care of assessments. So population health statistics, will help us to know what the access and quality of care is, whether we have environmental factors, demographic factors, and of course, to be able to measure the burden of that disease using metrics like disability-adjusted life years and quality-adjusted life years. For the purpose of my presentation, I just want to focus on disability-adjusted life years because I just want to refer us back to the ICF that talks about functioning and disability. The health statistics that we generate will show the population's health. So health statistics that is not tailored towards the person will not give us a true picture of the patient's health. So briefly, the disability-adjusted life years, what exactly does it stand for? It is a measure of the overall burden, of disease, disability, and premature death on the population. So I'm bringing out the word disability. So if we do not measure disability, if we do not look at disability with the eyes or through the lens of the person, we will not be able to have this metric well calculated. So the one value represents the loss of 1 year of full health, and is calculated by adding the years lost to premature mortality and the years lost to disability. And it's very, very useful, especially when we talk about public health officials, when we want to compare the impact of different diseases and inform policy decisions. So it is calculated, like I said, why the years of life lost and the years lived with disability. So it is still talking about disability and going back to the ICF. So these DALIs are used to measure disease burden. We can use it to compare health outcomes. It is about health outcomes assessment that is tailored towards the patient, towards the person. Guiding policy, helping governments and organizations to make more informed decisions about where to allocate resources. So it is important. It is important that we go back to that foundational shift of looking at our patient. Because if it is just about just measuring the burden of disease as talking about diagnosis alone, we will not capture what is meaningful to the patient. So how, again, do we now do this? Because we need to be able to integrate strategies for system-wide adoption of this person-first paradigm, a patient-first paradigm, a paradigm that is not paternalistic in nature, a paradigm that allows the patients to be active recipients of care. So the foundational shift from patient to person requires strategic integration at all cares of the healthcare ecosystem. I'm sure that we have people on this webinar that are into policy, into health governance. We need to advocate for policies that mandate the use of person-centered models, like the ICF, in collecting data and reporting patient-reported outcome measures data for quality reporting. I know we have so many databases that we can use to retrieve information about our clients, but I'm not sure whether we have PROMS databases, databases that talks about outcome measures. So at the system level of the policy and governance, restructuring funding models to reward outcomes based on functional status and participation, not just procedural volume. At the administrative, whether you're an administrator in the hospital or clinical setting, we should integrate person-centered principles, not just by words of paper or whatever, but ensuring that this is well implemented into organizational culture, training, and workflow design, designing clinical pathways that explicitly incorporate time for shared decision-making with our clients. Implement person-centered care champions or teams to drive change internally. Even the use of technology, electronic health records, for the patient portals can help to capture personal goals. I know we have not integrated so much of technology, but we will get there, where we're able to integrate technology to capture personal goals and patient-reported outcome measures easily. Even if we have to still use our paper instruments, we still need to capture patients' reported outcome measures. At the level of the provider, that is the healthcare provider, we should cultivate and master the essential relational and communication skills. Communication is very key, very, very key. Maybe there could be the need for us to have mandatory training in motivational interviewing and active listening in our clinical education and continued professional development. We should make it a routine practice to ask, when we have encounters with patients, interactions with patients, we should ask them, what are your 3 most important goals for this treatment? What is that thing that is most important to you? 3 most important goals for your treatment. At the level of the patient, that is that person. And anybody can be a patient at any point in time. And that is why it is important for us to look at the person behind the patient. We should look at that individual. We as healthcare professionals, we should empower our patients. We should empower them. We need to empower them to move from passive recipients of care to active partners in their health journey. We should provide clear, accessible education on their condition and treatment options and ensure that they have these health literacy skills. We should encourage individuals to come to our appointment with questions. They could ask us questions. These questions will help to facilitate the care that we give to them. I know that in the real world setting that there could be a little bit of problems. We need to bridge the gap. I'm sure you agree with me that there is a gap. There is a gap between patient-centered outcomes research and practice in the real world setting. There is a gap. But I know that where there is a will, there is a way. We can decide to join in this movement of patient-centric care. We need to join this movement of patient-centric care. Our patients must be empowered because they are individuals. They are also persons with stories. They have their fears, they have their concerns. And I'm also looking forward to a time when we could even have a center for health outcomes assessment, where patient-centered care is pivotal. We could have that. Maybe IAMRAT could look into that. There are so many departments in IAMRAT. We could look at having a health outcomes assessment unit. Interdisciplinary collaboration in research and clinical practice is very key. It is very, very key. We should encourage patient advocacy groups. Let patients have their groups. Let them have their own teams where they can discuss things that matter most to them. Databases of indigenous patient-reported outcome measures, I mentioned this earlier. We need to have these databases, and this movement can start with every single person that is on this webinar today. I'll be concluding very shortly. The shift from treating a patient, that is moving from diagnosis to patient to serving a person, a whole individual, is powered by 3 interconnected pillars. The ICM framework, I want this to be our take-home message. The ICM framework, to include function and participation, active listening, that is, we're building the therapeutic alliance and making the person the active partner, measuring what matters to the individual for true alignment, using patient-reported outcome measures. The future of meaningful healthcare lies not only in the next big technological breakthrough. Technological breakthroughs are very, very important, but that should not just be the only thing. But in the return to a fundamental human principle, seeing the whole person, this foundational shift is the most powerful tool we have to redefine the meaning of care and maximize its long-term impact. I'm going to leave us to end this lecture by leaving us with the philosophy, the Ubuntu philosophy. A person is a person through other persons. You are a person through other persons. I am because we are. Our patients are because we are. We are because our patients are. We should embody this Ubuntu philosophy. When we treat our patients, we treat them, we heal them because our patients trust us with their vulnerability. We grow because each person teaches us something new. Every single encounter that we have with our patients, every single interaction that we have with our patients, we will learn something new. Because no single patient, no 2 patients are the same. So we find meaning because we serve others well. We are stronger because we work together. I am because we are. The person-centered care, looking beyond the patient. Looking at the person beyond the patient is the way to go. And I'm just going to ask us one question. I started this presentation with a question. You know, I said, based on my title, even the title was a question, patient or person. And I asked us a question again about how do we treat our patients? When we treat our patients, how exactly do we treat them? I also want to end this presentation by asking us, what is one habit that we are going to change today in our interactions, whether you are an administrator, healthcare professional, a researcher, policymaker, anything, in our interactions with patients to ensure that we are not just seeing a person, but we are not just seeing a patient, but we are actually looking at a person. These are my references. I want to thank every single person for their attention. And I hope you all listen and you did not just hear me, that you all listened to my lecture. I will be so happy and delighted to take questions at this time. Thank you very much. I'm done. Thank you.
Thank you very much, Professor Odole. I can see the accolades just going through the screen. We are very grateful. That's really a very brilliant, illuminating, and very touching lecture which you have given. To be considered a person and not a patient is really a great deal. And these our patients really appreciate. And so for emphasizing this today, I think it's very important. And I'm sure our health professionals amongst us have learned so much. And definitely that your last question would be answered at some time. Maybe you want to send to Professor Odole your answer to that last question, which he challenged us with. That is, what would we change? How would we how would we treat our patients differently after this lecture? So we go on to the question and answer time. Is Professor Akinyemi there? Professor Akinyemi? Okay, so please, if you can raise up your hand if you have any questions, and also you can type in the chat box. Thank you very much. Anyone? Anyone who wants to ask question, or she has told us everything about what a person is and not a patient. Okay, we have Ifale Vincent. Please let our questions or comments be very short so we can give others time. Thank you. Ifale, you have the floor.
Thank you very much, sir. Thank you very much. Can you hear me now?
Yes, we can hear you.
Thank you very much. Thank you to Professor Odole for the wonderful lecture. I'm just coming from the point of view of the clinician and physiotherapy. At our center, we make use of output patient reported activity, but not as much as the doctors. I would say perhaps for specific conditions, and then I would say more generic outcome measures. And one of the challenges, and I think Professor Odole mentioned during the lecture that the uptake of patients reported, the uptake of these outcome measures by clinicians is still poor. I just feel that it's also important to hear the perspective of so one of you the absence of database available
Please, hold on, Vincent. Please, if you've not been asked to talk, please mute your mic. And if you are where Professor Odole is, we would appreciate if you do not talk, please, or you move out of the room where she is. Thank you. So, Vincent, quickly round up, please, your question.
Okay. So, I'm saying from the perspective of the clinician, it will still hold a whole lot of things. We can have available databases where we can have these outcome measures. Then also, if I, for example, if I'm searching for an outcome measure and I'm seeing the items in the outcome measure numerous, I personally as a clinician, I would be discouraged from using such as outcome measures. So if I had one, my conclusion is that we should get the perspective of clinicians who are the ones to use this outcome measures. Then we can get databases available, and then designing the questionnaire or the outcome measures, not just for patients with the patient in mind, but also for easy use for clinicians. Thank you.
Okay, thank you. Let us hear Ifeoma. Please be brief, and then Professor Odole can respond, and then we have Professor Falusi. Thank you.
Good evening, everyone. Mine is actually not a question. I just wanted to commend Professor Odole for that wonderful presentation, and to just add or lend a voice to what she had just said, because I work as a community physio. I would understand that the presentation and the idea of our goals being patient-centered, and especially what she said about when Mama's issue was how to tie gele. I chuckled because it actually brought home some of my experiences working as a community physio, because right here, working in the diaspora as a community physio, you would understand that it gives life to this presentation she just had, because more than what I would say in our documentation, more than just having your goals and objective. In fact, we go a step further to say the patient's goals. What the patient is inconsequential. It's not like it doesn't have consequence what you as a therapist want to achieve with the patient, but more than what you want to achieve for the patient, it is what the patient feels is their main objective. So I would say we can never overemphasize that important aspect of patient care. But the only part I may just be wondering is, for me in the community physio, seeing 2 new patients a day is like a full day for me. And that's because we do like holistic care. By holistic care, I mean that apart from the physiotherapy aspect of things, even the nursing and the care part of things, we also take into consideration all that. But what I'm envisaging is the challenges that may ensue if we're going to take that approach or implement that kind of full approach in a busy outpatient clinic. Thank you.
Professor Odole, your response, please.
Oh, okay. Thank you. I was thinking that I was going to respond after everybody. Yes, thank you, Vincent.
Is that what you prefer?
No, it's okay, ma. Let me just respond. Yes, thank you, Vincent, for your question and the concern. We're talking about sometimes when we have bulky outcome measures. Really, some outcome measures may be very bulky, but they would have different domains. And it is not in every instance that the domain would be important, that the domain will be important to the patient that you are seeing. For instance, if I'm to go back to Mama that I saw, I don't even need to have any instrument. I could just use, as simple as the visual analog scale is, I could just make 0. Mama cannot tie the headgear, 0. 10, Mama can tie her headgear fully, and just use that to track that important single function for Mama. So depending on what the patient's problems are, there are existing instruments that you can use that are not really bulky, And about getting a healthcare professional therapist perspective, yes, so many research has gone into that. It's because my presentation is not just about health outcomes assessment. I would have made reference to some of the things that we have done in terms of the facilitators and the barriers to the uptake of patient-reported outcome measures in Nigeria. Thank you, Ifoma, for your concerns. And I think with that, for your comments, rather. I think with that, if I'm not mistaken, I think when you talk about having just 2 patients on a day has been very full, I'm thinking that maybe you are using the interdisciplinary care, where you have this integrated approach to care, where so many professionals see a single patient. Thank you.
Thank you very much, Prof. Professor Falusi and Professor Aneto. Professor Falusi and then Professor Aneto, please. Thank you.
Thank you very much.
My dear director, our former director, man, we salute you, man. Thanks so much for being there for us all the time. So
thank you for inviting us.
Yes.
Keeping us current. And today is a particularly beautiful day for me because everything she's spoken about is what we are thinking of in my foundation. We have a foundation called Sickle Cell for Life Foundation, and we work closely with sickle cell patients, from babies, from little children to adults. And we have simply incorporated now something called a Mothers of Warriors in Action, because there is so much. Everything you have said is very true. And I'm so excited to be part of this discussion because this communication is really a therapy for these patients, because those of us who are not medics, we are researchers. When we go out in our with our foundation awareness and counseling and things, what we hear at times shocks you, because somebody tells you that in their house they've been using broom to beat her for so long that in fact, she doesn't relate to them as family. She wants scarf mother to be their mother, that kind of thing. So there's a lot out there that the medical, the statistics, the data cannot capture. And for their health, it is important, like you said, to incorporate some things like this. Sometimes even their religion doesn't allow them to express themselves to the doctor and to take the needed care. Sometimes it is empowerment that is missing. And this we are seeing in SCAF. Many of them don't even have the money to come for their regular appointment. And the doctor says, oh, you missed your appointment. Why are you missing your appointment? Nobody knows. So there is so much out there that we need to look at. For example, the passive nature is already entrenched in our system. People just, the doctor knows everything. And then they go there with that mindset because they feel they cannot ask questions. Whereas in other countries of the world, like you said, the patient already reads everything in the Google and comes there prepared to ask the doctor, why are you giving me this? Why are you doing this? And then she gets to know better. But here we don't even have the time because the doctor is overburdened with 200 patients in a room that has no light. Sometimes I feel sorry for them when I go to GOP or MOP and I see them. They are with all these patients. There is no light. There is no window. There is nothing. And then you have so many to take care of. You cannot do all these things. So in all of this, we in SCAF have published a book. We said voices is what we said. Instead of doctors talking for these patients, they have headache, they have leg ache, they have bone pain, they have this. Why can't these patients be allowed to speak theirs? That's what the book is about. I have a reference for it, which I can share. And more importantly, we are saying that This passiveness, we have to overcome it among patients by talking to them as real individuals that are partners in this health process. And in that wise, I don't want to belabor the point. I want to ask you a question directly. What do you think the role of an NGO in an institution is? For example, in the NGO, at least a related one, we have communication to the grassroots level. We talk to them, we see them, hundreds and thousands of them when we go on campaigns and things like that. And they tell us a lot. What do you think there is a role? Because in other countries I have seen where an NGO, when a patient is answered in the clinic, as soon as they come, they are referred to that section of the hospital to talk to the people there. The people will have time for them. And this is where we come in as NGOs, and we can reach the patients at the community level. I think that community level aspect, although there is public health, there is all the other ones, but I am asking, is it possible that an NGO that is directly related to certain areas of the hospital can be allowed to put in their expertise, be allowed to reach this community at the grassroots level to get the outcome of holistic care? Thank you very much.
Do I respond now? Professor?
Please.
Maybe let Professor Neto.
Okay.
Please let us be brief.
Okay, yes, thank you. Well, thank you very much for a very illuminating presentation. Well, I will round up with a question at the end, although it's essentially a comment. And I want to tie this with what a senior fellow said, who used to be a student at the University of Ibadan, then became a faculty in America. I want to liken what you are discussing with our approach to our students. I think it's the same thing. I am the lecturer. I am the so and so. So when are we going to adopt a true pragmatic collegiate approach to patient management? I know some of us are now no longer actively at the stage, but I'm glad that this is coming up. There has to be a paradigm shift. If indeed we are putting the patient at the center. At the moment, it is my territory. It's invading my authority. This is it, and it's sad. And I'll just give an example. At times, we make a mockery of ourselves. I met a retired professor from the Faculty of Agric who was being managed, and then he raised some questions with someone who made a suggestion about an investigation he should add the managing doctor to add. And then the patient, a professor, mentioned it to the attending physician. And he said, this is not research, I'm in charge, something like that. So, well, that was it. And the doctor, the patient, the professor, just followed what he was told. And then why I said we make a mockery of ourselves, this is somebody who has access outside and had to go abroad. And one of the things they asked is, why was so and so not done? So at times in this rigidity of authority and I'm in charge and all that, the patient suffered, assuming that patient didn't have that privilege, So just to round up, we honestly have to try to put these things into practice, pragmatically, not just listening and then nothing changes. The Professor Olopade I was talking about told us at the Trenchard door many years back that when she left Ibadan, she go to America in the classroom and was shouting on students. And at a point, they called her and said, we don't treat our students like this in America. So she had to change. So I liken today's discussion to that situation in America. We have to change. We have to be globally compliant in the management of our patients, in the treatment of our students, or handling or relating with our students. So this is it. So my question to you, which I know might be difficult to answer, is what do you think might be the pragmatic approach to ensure that this also takes place in Nigeria. And in particular, I think we should start gradually inculcating this patient-centered approach, student-centered approach to the next generation of faculty, the students. Thank you.
Okay. Should I respond now?
Yes.
Okay, so I'm going to thank you, Professor Falusi, for your comments. I'm really so excited when you talked about the mothers of warriors in action. Very, very excited. I belong to 2 NGOs myself, and I know that the power of NGOs cannot be overemphasized. I agree with you, I concur. Anything that would have to impact on meaningful health outcomes, we should integrate. Having NGOs, you know, I talked about having a center. Maybe if we have a center for person-centered care or center for health outcomes assessment, and we have NGOs affiliated to such centers, maybe that would help us. That would help us to integrate NGOs in whatever care that we are delivering to our clients. And communication is therapy. Thank you, Ma, for using that word. When I was presenting, I said communication is key. Communication is therapy. I cannot begin to tell you how many times that I didn't even have to intervene to do any physiotherapy on the patient's first visit, and we just got outcomes. So communication is even therapy, is therapy. So NGO, I think I support that. There's a lot of things that we need to look at in the College of Medicine, University of Ibadan. We can be the trailblazer. Let's have a center for patient-centered outcomes. I'm not sure we have that in any health institution in Nigeria. Then, to refer to Professor Aneto's concern about pragmatic approach, I think one of the things that we have even done with this presentation today is to raise awareness. We should move away from this paternalistic thing. And one thing that we can do is to empower our patients. Every encounter that we have with patients, every encounter that we have with research participants, let's empower them. Let them know that they have a right. A patient's BP taking, the BP must be explained to the patient. I know, you know, it's a movement, sir. It is not something that will just happen in a day. You know, for anybody that is still holding on to the paternalistic approach of care, such individuals are myopic, so to speak, very myopic and short-sighted. Person-centered care, when we look at the patient through the lens of that individual, that even I can be a patient at every time, I think that would help us. We'll just keep talking about it, and then maybe setting units or whatever that would help us to be pragmatic about it to an extent. I don't know if I've been able to answer that question, Professor Adesola, because it's a huge one. And that was even what spurred me on, that we need to hear this. We need to hear this. That is about, nobody owns a patient. Patients are non-material things that people will say I own. Patients are individuals like you and I. So we need to be focused and do what is best for our patients and clients.
Well, thank you very much, Prof, for the response. Maybe I can just add to that, it's a clarion call to health professionals. However, I must mention that we have the family medicine discipline that actually have the patient-centered approach to care being a key domain of care, and is very paramount when we're talking about family medicine. So it will be a good thing if, I'm sure some of them are on this webinar, and definitely you've added more to the knowledge and sharing, and I'm sure you will, it will be good you really work with the family medicine department, or you work together, let me put it that way, because there's a lot in terms of training on patient-centered care in family medicine. And just to mention that, and also the fact that you work with the NGO, and also Professor Fadusi. I'm so happy because at the end of the day, we're talking about going to town. The NGO are the eyes of the community. So if you can work together, that's a way of really getting all we're talking about, all our research findings as to the effectiveness and advantages of practicing patient-centered care across. That's really what is part of translational medicine or translational science, getting knowledge to those who need it within and outside the hospital setting. So we have Michael Ogunleye, Onyeso Ogochukwu, and who else? So let's take the remaining participants' questions. Please make it brief so that Prof can give us a response that would really be, she will have time for her response. Thank you. So Michael Ogunleye Ogochukwu, and then we will go to the chat thereafter. Thank you.
Good afternoon, ma'am. Thank you, Professor Odole, for that wonderful presentation. So, as I was trained, I believe that the patient-centered care is very important and very essential in managing patients. But my question is, when it comes to a case where the patient has been given unrealistic expectations by another medical professional, how do we manage that? For example, as a young physiotherapist, I've carried out my assessment using outcome measures such as the Oxford Muscle Grading Scale, the NPRS for pain, activity, and disability, like we talked about, even the ICF. And I've judged based on these outcomes that the patients cannot perform certain tasks within this certain time, and within a certain time, for example, 2 to 3 months, she should be able to do this or do that. But based on the advice from the senior medical professional, such as a chief consultant, the patient was told in a month or in 2-3 weeks, he should be able to do this or do that. And that is what he believes in. That is what his mind is stuck with, because he believes that chief medical professional has more experience than myself, a younger professional, irrespective of my assessment and the outcome measures, which we have both looked at and which we've both assessed, and using SMART goals. So how do I address this to regain trust in the patient and to explain to the patient that this and this is what we need to do, is to take more time, regardless of what the chief medical professional has told him, and notwithstanding, not excluding his own advice completely. Thank you, ma'am.
Okay, I think it's my turn. So thank you so much for.
Oh, yes, sir.
Okay, thank you so much, ma. Thank you, Prof. Odole, for that brilliant presentation. So my question will be very brief. So I want to start with the NGO. So that's what I also like to be incorporated. But my question is, in some of our settings, we have the medical social workers, and I think they are also contributing to that aspect already. So maybe my question would be, when the NGO comes in, are they going to be doing the same thing, or just to augment that institutionalized resources we already have in some centers, actually, not in all centers? Then the last one is can you hear me?
Children's Financial Services. We set up a life insurance policy for you back in May. And we did get notification it cancelled. Was there any particular reason you cancelled the insurance?
Okay,
can you hear me?
Because I already had a life insurance in place, right?
Somebody is.
Okay, can you hear me now?
Okay, we can hear you. We just have this.
Someone is taking over the thing.
Yeah, there was an interruption. Maybe somebody joined with a microphone on. So the last one is Ifoma talked about them in another setting having like 2 patients in a day and taking their time to do all these. And the I've forgotten the name of the professor that talked about pragmatism. So my question is, in a very low resource setting where workers are like underpaid, overworked, what is the feasibility of doing this? For instance, where I did my internship, I know sometimes there are some physiotherapists that see 5 to 10 patients a day. Just oppose that to Ifoma that see only 2 patients a day, and she's well remunerated. And in the other side, people are being owed salary, owed a lot of their allowances and all that. So how does all these things come in reality? So my worry is who is supposed to be listening to this in terms of policymakers that should make a work environment even better and kind of make things even easier for the practitioner. Thank you.
Okay. Thank you for your questions. Michael, you talked about when you have unrealistic expectations from a more senior colleague. You know, patients coming with unrealistic expectations. Well, you know, we have a lot of problem here talking about our context, but that should not deter you from doing what is right. And that is why therapeutic alliance, you need to have this therapeutic alliance with your patients at any level. Even if the patient is coming from a very senior colleague who has given the patients unrealistic expectations, get your patients to yourself, communicate with your patients. In this world of internet, patients get to have information too. They can read up a lot of educational materials. Let them be health literate. They are individuals. They will get to know the truth. Tell them exactly what it is, that this is what you can, this is it. If you feel the patient will not be able to run in 3 months, and there's an expectation that the patient will be able to dance in 1 week, and that expectation is not something that is realistic. You just do what you know how to do best. Get the trust of your patients. When a patient gets to trust you very well, and the patient gets to know that you are doing the best for him or her, whatever unrealistic expectations could be eroded. And sincerely speaking, I don't know. If the proper diagnosis has been made, why would a senior colleague raise unnecessary hope for the patients? The issue of the concern raised by Ogochukwu is institutionalized centers, like when we talk about medical, social workers that we have in low resource settings and the NGOs taking it up. One thing that we need to do is that everything that we do must be complementary. In institutionalized centers where you have medical social workers, sometimes what they do most of the times, they want to be able to see if the individuals can be integrated back into the community. The use of outcomes that matter to the patient is not in the domain of medical social workers exclusively. It's not in their domain. So we are still talking about working together, interdisciplinary thing. So we are just using the NGO, like the town, people, you know, the NGOs, most importantly, sometimes they even have the financial capacity to help. So the fact that we are introducing NGOs to help out does not mean they are replacing what we have in institutionalized centers. Then the concern about low resource settings where people are not being paid and their morale is really very low. Well, to me, what I've always done, I'm just going to share my own personal experience. I've always had this approach to life that I'm accountable to God for everything that I do. It's about any encounter that I have with somebody, I have the responsibility of giving my best. So we can have a way of managing. There are so many things that we can manage, even when you have a very busy clinic. You don't necessarily have to treat on the first day of the clinic. That is the way I see it. If the patient is not an emergency, I'm talking about physiotherapy now, my discipline. If it's not an emergency, you can dedicate 1 day for only plaquing and tracking using outcome measures. You don't necessarily have to treat. There are ways around it if we want to do it. If we know that that is what is best for our patients. And if we know that that would also help us too and reduce the frequency of visits to our clinics, I think it is something that we can do. I don't know if I have answered your question.
Thank you very much, Prof. Let's quickly go to the chat. Professor Fakmonle, you're welcome. Thank you for attending. There's a comment there. She wrote, you raised very germane points, but how do you manage time in your clinic, especially knowing that what you are advocating will take time to implement with every patient, especially with our busy clinics? Let me read others so you can take all of them at the same time. We have Professor Akinyenka Omigbodu. You're welcome, sir. Thank you very much, Professor Odole. You have thrown more light on a very important issue in patient care. I wish many more students of health professions who interact with patients will get to hear these concepts that you have so competently shared. You need to do more to make your assessment tool better known among health professionals. The more we look out for quality of life issues in patients' care, the more invested our patients are likely to be in following through on the care recommended to them by care providers. Thank you very much, sir, for your comment and suggestion. The other, I think those are the comments. There's another one, Frank Oronsoye. How do we implement this at lower level of care where majority of the populace go? Chinedu Babalola, our dear VC Emeritus. She says, this lecture is a call to harmony among healthcare providers in attending to patients and persons. And then there is Olubukola Salam. If every physician specialist could adopt the patient-centered care and the biopsychosocial approach like we, the family physicians, there would be a paradigm shift in our patients' clinical outcome and satisfaction. There would be a need for more advocacy. Well done, ma'am. Professor Falusi has spoken. So those are the comments in the chat. Please, I think you need to respond to just one of them also. Thank you.
Okay. Okay, ma, thank you. Let me just respond to Professor Fakole's concern about time management. I think we have the power to manage our time. Like I just said earlier on, I can decide that I just want to obtain data today. If it's not an emergency, I don't have to run through all of the steps in clinical decision-making on one day. And we can decide to have that, okay, outcome measures, when it comes to outcome measures, we could have a unit in our department. So we have somebody whose job is primarily to use patient-reported outcome measures and documents. So if I just document the score of this patient on the Beck's Disability Index is 7/2 and over 10. I'm just saying this abstractly. And we can always find a way of managing it and ensuring that we do not overwhelm ourselves too much, and we are still able to get into the patient-first paradigm. Thank you, sir, Professor Kibodru, for your comments and suggestions. I really do appreciate that, sir. Then Frank Morosowo, implementing at lower level of care where majority of population go. Do you mean when we talk about the primary health center? There's nowhere we cannot implement it. There is nowhere. It could even be as simple, even if we do not have the questionnaires, simple as the VAS, 0 and 10, and just using it to assess and track progress at the person's level. I think that's another way to go. Yes, advocacy. Thank you, Dr. Salami. I think we need to raise our voices more so that we would have collaborations with family physicians. Let's begin to look at this development of a center where patient-centered care is the voice, is the way to go, is the gospel that we are preaching. Thank you.
Oh, thank you very much, Professor Odole. It's been a very illuminating, how do I put it? Very illuminating, brilliant, informative lecture. And you can see that all of us have one thing or the other that have been gained and to be applied. Someone have said, I'm going to be a better physician after this lecture. So thank you very much. But before we go, we need to recognize all the participants for being with us in the last 1.5+ hours. And we very much appreciate everyone. But we cannot but again single out a few of our professors, our legends. We have Professor Falusi, who is also the former director of the Institute and a great friend that has actually supported this IAMRAT lecture series. We just latch on what the foundation she has laid as a director. We also appreciate, still an legend, Professor Laiton Shoyanwo, who is a palliative care specialist. I'm sure all we have said today also applies to palliative care. And we also have other professors amongst us. We really appreciate everyone. Professor Chinedu Babalola, who is also one of us here at IAMRAT, but we cannot but mention she's a former Vice Chancellor, and that's the Christland University Vice Chancellor. Dr. Mrs. Ajuwon, the Chief Librarian of the college, also joined us. We appreciate your representing the ESCO of the college. And then we also have participants from other universities. I can see Obafemi Awolowo University and some other universities, and also those from international. We have the international audience with us. I believe Professor Odole must have also shared with our network. We really appreciate all of you for joining us. And I want to thank the IAMRAT staff too, who have put in their best to get all these lectures out and at every month, and also getting the very important experts to share their experience and their work with us. We are very grateful. So to everyone, I say thank you for coming. Please, if you have not registered, kindly do that, and let us know if you need CME. So I think we want to say thank you and bye-bye. For the month of December, we shall not be having the webinar. We use that time to take record and write good report on all we have done in the year. So we want to say, please join us again next year, 2026. We wish you a Merry Christmas and a Happy New Year, and see you January 2026. We've already lined up very interesting lectures for the year 2026. Thank you once again, Professor Adesola Odole.
Thank you, Ma. Thank you for having me. Thank you, everyone, for participating.
So bye-bye, everyone. Thank you. Professor Migbadun, I believe I recognized you, yes, of our former provost. Thank you so much.
Thank you.